Hello, everyone. It's Dr. Lisa L. Campbell. It's week 2 of your Introduction to CPT HCPCS coding course. This week is all about evaluation and management coding. Some say that evaluation and management is difficult, and I think that there's just so much information in this particular section of the CPT manual that you really have to be intentional about how you attack the material. So, the very first thing that I will tell you before you even read the textbook chapter, it's in your best interest to read the guidelines that are on the green pages in the front of the evaluation and management section. This will serve two purposes. Number one, you need to read it. You actually need to read it more than once. But number two, it will help you understand what you're reading about in the textbook. Now, I will tell you that this textbook is written at the most basic level. And so you should find it not as difficult to understand, but it is a lot of information, and more than likely, I will be presenting this in two parts. So, what are our objectives? Number one, in the beginning of the chapter, they give you some key terms related to E&M coding. So instead of saying evaluation and management, here on out, I'm just going to say E&M. Next, locate the codes in the subsection and subcategory of the E&M section. And remember, I talked about how we have the section guidelines in the front of each section, but then embedded in the section, we have subsection notes, we have parenthetical notes, we have coding tips, all of which you will see here in this chapter. Something else I want to mention, which is food for thought. Now is the time to read these guidelines and understand them so that you can apply them. If you wait until school is over, now you're studying for the exam and you're trying to look at all these guidelines, it's too much at that point. You really need to have read them and understand them by the time you leave the program, and then, continue to focus on the application. Number three, identify the documentation that's needed to justify the E&M code. Four, understand the difference between a new and established patient. Five, select the place of service codes. And we actually talked about place of service codes. They are placed on the claim form. And generally speaking, they are not placed by you as the coder. However, you could work in an office where it should be when you put the code in, the system should know what the place of service is. So, for example, office visit, it should know that it's an 11. But place of service is a concept that you are expected to know for the CCSP exam. So don't sleep on any of these concepts, okay? Next, explain the consequences of submitting an incorrect place of service code. So let's say the patient was seen in the inpatient hospital, which should be place of service 21, but you list 11. It's going to mark it as an error, right? And it's going to say it's a mismatch. It doesn't go together. All right. And then classify the parts of the patient's SOAP note and medical history. Eight, state the documentation requirements for a consultation. Nine, choose the correct E&M code. 10, explain the rules related to, these different subsections that are in E&M. And then number 11, identify and code procedures for E&M from case studies. So please keep in mind, this lecture is no substitution from reading the textbook. All right. Let me get a sip of water, and my throat is getting dry, and let's get going. So, when we talk about E&M, we're talking about that initial encounter that the provider has with the patient. And at the conclusion of the visit, there's a plan that is put in place. Plan could be follow up in a year. Plan could be to have some labs. That information is going to be in the medical record. And the really the complexity of the E&M service is really going to determine how much the service is reimbursed on today. The patient is not that sick, the reimbursement is less. The patient is sicker, reimbursement is more. Patient is in the hospital, is going to pay more than um, the patient in the doctor's office. So having the correct code along with the documentation is going to be important. So once you go past the guidelines on the green pages, what you're then going to see are the different subsections. So if you turn over in your CPT manual, I think it's like page 15, maybe. I think so. And if you turn over there, you see office or other outpatient services, and then you see paragraphs of information. Those are the subsection notes. Immediately following that, you see new patient, and then if you turn the page, you'll see established patient codes, and each code underneath it has a description that makes that code unique. And so the documentation is what we use to align with the service that we're going to report today. So we have office visits, we have telemedicine in the form of audio only, audio visual. We have, of course, our hospital visits, and our hospital visits are divided into if it's a hospital observation, if it is a admit and discharge on the same day. And so you'll want to take some time to review these different subsections because they each have, you know, rules that apply. So I've already talked about the fact that we have those guidelines at the beginning of each section. They really set the stage for use of that section. They're designed to help you select the correct level of service. And so failure to read them, understand them, leads to not being able to apply them. So, selecting a code is really based on those guidelines. And I've already said, the need for you to review them multiple times. And here is the thing: the first time you read them, it's going to be like, blah, 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 blah. Now, in the book, they talk about mark up the information in the guidelines so that you're able to locate them. Let me just give you a word of caution. You don't want to mark up your book, highlight your book so much that you can't find anything, that you're overwhelmed. And so I would say don't start to mark up until you've read them at least 3 times so that you have an idea of what you really need to mark up. The first time it's like so foreign that you're like, yeah, I don't know none of this, okay? All right. So COVID really brought telemedicine to the forefront, and services are continuing to increase. Now, I think I mentioned this, but I'm going to just reiterate. Just because there's a CPT code for a service doesn't mean the insurance company is going to pay for it. But nonetheless, I already mentioned that we have codes for audio video, audio only. Notice it says synchronous, and synchronous means real time. Okay. Um, these codes are actually new for 2025, and so they are actually located immediately after the office visit codes. And one of the things you'll notice, just to kind of reintroduce the symbols that you see in the CPT manual, you see where these codes begin, the subsection notes, the word telemedicine has the facing triangles. And remember, the facing triangles mean new or revised text. And then you see, let's see, like one, two, three, four, five or six paragraphs of information regarding telemedicine. And then you actually have a telemedicine and non face to face services table. All of this is new for 2025. Remember, I said the AMA has the annual CPT symposium in November, and that's where they go over the rationale for the new codes for the year. All right, so E&M changes. One thing that you will want to know, especially for those of you who sometimes will Google things, or you're trying to use some type of AI to get information, the codes in the E&M section were actually updated from a methodology approach January 2021 for office visits, and then the other services that you see listed here, January 2023. So, not that new. Reason I bring this up is because you're going to probably run across some old information. And it's important that you understand that we are following the rules that are in our 2025 manual. And so you want to review those guidelines. Very, very important. There is a list of the new codes, revised codes, deleted codes in Appendix B. And you can review this to see what the E&M changes were. And in particular, we have these new audio visual, audio only codes for 2025. All right, so selecting codes, and we're starting with the office visits. And so those are right before telemedicine. And as I'm going through these lectures from week to week, it's actually in your best interest to follow along in the CPT manual, because that way you can, maybe put a sticky note on something that you need to go back to. So, office visit code starting with 99202 through 99215 minus 99211 are selected based on one of two approaches: either A, total time on the date of encounter, or based on the level of medical decision making. In the description of the um, code, you will see something that says which requires a medically appropriate history and or exam. It used to be that we would count history and physical exam as a part of the code selection, but that went away with those changes that I mentioned January 1st, 2021 and January 1st, 2023. So, a medically appropriate history and physical exam should be performed, but it is not part of the code selection. We have two choices for office visits: total time on the date of the encounter, or medical decision making. And I'm going to again encourage you to read the guidelines. All right, so inside of the code descriptions themselves, right after you have the paragraph that talks about medically appropriate history and physical exam, and then it says the type of medical decision making, which changes from one code to the next. So, when we talk about what you should highlight in the book, you may want to highlight 99. This is just an example. 99202 is straightforward medical decision making for a new patient. 99203 is low level medical decision making, right? But again, don't just go highlighting your book up, because once you mess it up, you got to pay to get another one. So really be strategic in how you're going to highlight in the book. And next week, I will introduce you to a strategy that is pretty popular that you could use to highlight your book. The other thing is, you'll notice that each code has the total time. So, for example, 99212 says 10 minutes must be met or exceeded. So, one thing you should understand is that if you're going to level the service based on the total time on the date of the encounter, the total time needs to be documented in the medical record. All right. So, for 99202 to 99215, the time spent for the encounter actually includes a list. And so if I go to, and right before the office visit codes, there is actually this bulleted list of what's included in time when performed on the date of the encounter. The reason why I say the date of the encounter is because total time can include preparing to see the patient, reviewing tests. So let's say you work with a provider who reviews the charts the day before. That review cannot be included in the total time because it is not on the date of the encounter. So, again, one of the reasons why I want you to read these guidelines is because you really need to first build knowledge of them, second, understand them so that you can third apply them. In the CPT manual, you can see all of the information regarding time. So, in the E&M guidelines, you should locate the section with the heading of time, and you should go there now. I'm going to turn over there myself. And what it is listed as, it's guidelines for selecting level of service based on time. This is important because different categories of E&M services uses time differently. And so what that means is you can't make the assumption that every time a code has time in it, that the methodology is going to be the same. We also have what is known as a split or shared visit. That's when you have a physician and a mid-level provider that's working together. So there are rules for that as well. And then we have something called prolonged time. And in the prolonged services codes, there is some time language there. And so the key takeaway here is that the rules are not the same. All right. So when you are selecting your E&M code, there's really three questions that you want to ask yourself as you go to the index, right? You want to ask yourself, is this patient new or established? Because many of the codes that are in the evaluation and management section are organized based on if the patient is new or established. You also want to identify what's the location of the patient, because we have codes for nursing home, emergency department, you already know, office visit, inpatient, outpatient. And then lastly, what is the degree of the service rendered? You're going to find all of this information in the medical record. And so when you know the rules as you're reading the record, you can actually apply the rules. So the CPT manual does have an official definition of a new patient versus an established patient. So a new patient is one who has not received any professional services from the physician or qualified healthcare professional, or physician qualified healthcare professional of the exact specialty and subspecialty who belongs to the same group practice within the past 3 years. In the guidelines on the green pages, there is a section on new and established patients. So, an established patient is one who has been seen within the last 3 years by that physician or qualified healthcare professional. Qualified healthcare professional is a physician assistant or nurse practitioner, for example. All right, so same specialty, subspecialty who belongs to the same group practice. So, let's say there's a group of internal medicine physicians and you see one, and then 2 years from now, let's say the one you saw isn't available today, so you see another internal medicine provider in the office. You would be considered an established patient because it is the same specialty in the same group practice. So one of the things, as you build understanding, knowledge and understanding of the material, is you have to look at each and every word, each and every sentence, and really pull out what are the key things. Okay, so again, in the manual, there are some rules for new patient versus established patient. There's also a decision tree for new versus established patient, which is a really cool tool. And if you are working with a provider face to face, this is actually, if there's some confusion, this is a great tool to show them for clarity. All right, so place of service, I told you that this is a claim form situation, and it's basically driven by where the service was performed. So in the inside cover, right behind the page that has the tabs on it, you have a list of place of service codes for professional claims. Again, the place of service is really something that you need to know for the CCSP exam. So please keep that in mind. So for those office visit codes that we just talked about, with the exception of 99211, code selection is based on either total time on the date of the encounter, and there is a list of activities that can be counted as total time, or based on medical decision making. So if you go back over to 99202, for example, you'll see that that's straightforward medical decision making, or the 15 minutes. 99203, low medical decision making, or the 30 minutes. 99204, moderate medical decision making, or 45 minutes. 99205, high medical decision making, or 60 minutes. All right, so specific criteria has to be met in order for proper code selection. So we talked about the new versus the established patient, but we also have to have that documentation. Remember, we had that statement, if it wasn't documented, it didn't happen. And so you, as the coding specialist, should always review the documentation that's found in the patient record. Now, this week in the insurance class, I talked about encounter forms, charge ticket, super bill, right? One of the things I have found is that sometimes the physician or nurse practitioner, physician assistant, they assign the code, they just circle it on the form, and then that code is entered into the system. One challenge with that is if the provider has not been properly trained, they may not know the rules and may, in fact, assign the incorrect code. And as you should know, or you will learn in the lecture this week for insurance, the insurance company can come back 5, 7 years, ask for the medical record, and learn that what you said you did was not exactly what you did. Okay. So we have to review and understand those guidelines so that we can apply them. So I talked about the decision tree for the new versus the established patient. Again, you want to take note of that. You definitely want to read through the guidelines and just start to let it absorb. It definitely takes more than one time. Also, in the guidelines, and I talked about this already, there is criteria for capturing a service based on time. Take note of the categories that use time because not all categories have time. For example, and this is for obvious reasons, the emergency department time is not a descriptive component, right? Because there's no way. All right. So when we talk about documentation, every record should have a chief complaint. That's the reason why the patient is there for today's visit. It is generally stated in the patient's own words. Um, my stomach hurt, my neck hurts, whatever the patient is saying, that is the reason for today's visit. It kind of sets the stage for what happens next, right? Then remember, we have the medically appropriate history and physical exam. And so, as it relates to the history, this is just an understanding of how this thing that they came in today for occurred. So, for the last 3 days, the patient has had fever, diarrhea, right? And so, as the physician or non physician practitioner has a conversation about the patient, or with the patient, they start to record information regarding the patient's history. Now, keep in mind that our overall code is selected um, in a lot of cases in E&M based on total time or the complexity of medical decision making. But doctors are not going to say in the medical record, my medical decision making was complex. Now, I have seen some of them write that in there, but generally speaking, you're just going to document what they did, right? So when the patient first comes in, they gather what is known as a history of present illness. That history of present illness, also known as HPI, includes the chief complaint. It includes again, the history of the illness. How long have you had it? What makes it better or worse? So they ask the patient questions. And then they get into what is known as a review of systems. Review of systems is where they're asking questions like, have you had diarrhea, nausea, vomiting? What they're trying to do is really narrow down what could potentially be wrong with you. So as they gather the HPI and they start to review the different systems, they can say, oh, well, the patient doesn't have XYZ because they're building a working diagnosis. The patient most likely doesn't have XYZ condition because they denied X, Y, and Z. All right. They also cover, when appropriate, any information about the patient's past history, family history, social history, such as do you drink, do you smoke, all of that. So review of systems is really an inventory of the different systems, and they're not necessarily asking questions about all the systems, but the ones that impact what the patient is coming in for today. Review of systems is not an exam; it is an inventory. You may have seen a review of systems form, like they'll ask you, have you had such and such? Are you experiencing such and such? That's a way to capture review of systems. All right. Past history, information about the patient's past, medications, etc. Family history, anything about their family that could impact today's visit. So, a patient has a lump in their breast, they have a family history of cancer. That could be pertinent. Social history is about you socially: drink, smoke, where you work, did you have sex, questions like that. Generally speaking, the clinicians are going to document in what is known as a SOAP note format. So, that information that I just talked about, HPI, review of systems, past family social history, that's known as the subjective portion of the note. Objective is when they actually examine the patient. And then assessment is the diagnosis, and the P plan, what they're going to do about it. That is where you will see the medical decision making. So, past history does include information regarding the patient's major illnesses and medications, as I said. It also includes things like if the patient is allergic, have they been hospitalized? And so, past history could impact the medical decision making process. And so, it's important that when it applies, it should be documented. Same thing with family history. Remember, the history and physical exam is not a part of what determines the code level, but it needs to be documented medically appropriate, I think is the key. Okay. Social history, I talked about, do you drink, do you smoke, all those things, where do you work at? Maybe you work at a factory and you're exposed to asbestos, you're exposed to dust, right? That could be the reason for a respiratory illness, for example. All right. When they examine the patient, they could examine one single system or multiple systems, right? So if you have a fever and nausea and vomiting, they, will look at your stomach, examine your stomach. Um, they may look in your ears, right? They'll listen to your heart and lungs. But what they do is really based on what's going on with the patient. So when we talk about body systems, it's those body systems that you learn about in medical terminology and anatomy. Okay. So I'm just going to click through these because I wanted to get to here, which is medical decision making. All right. Now, medical decision making is has layers to it. All right. And so, medical decision making, there are four levels. There is the straightforward, which is the low risk to the patient, low, which is also a low risk to the patient. We have moderate, which is a moderate risk to the patient. And then high complexity is a high risk to the patient. So, straightforward is your least sickest patient, high is the sicker patient. So, there's four levels of medical decision making: straightforward, low, moderate, and high. So the medical decision making process, remember that SOAP note? They got the diagnoses and now they're going to talk about what they're going to do about the condition, right? So, do we order blood tests? Do we order x rays? Do we need surgery? Do we order medication? All of that comes into consideration. Is this an acute problem, something that's happening right now? Is it a chronic problem that's resurfacing? The provider is making decisions about all of that. All right, so I have been talking for 30 minutes, and what I am going to do is stop here and I will pick back up with part number two of chapter three.